Yeah, thank you. And I'd like to thank Daniel and Gregor for having us at Live Center for this very good, very educational meeting. So let's show you the case first, of course, and my fellow Abdullah.
Good afternoon. 76 years old man with clear medical background present early this month with inferior STEMI, primary BCI to LCA, and this LAD angiography.
I already insert a sheath for the right radial if I do ping pong. So otherwise, I think EBU will be enough to see the distal artery of distal LAD because there is ipsilateral collateral here. In our setup, we have a 7 French EBU from the right radial, and from the left radial, I have only sheath 7 French. It's ready to insert another guiding if I need it. I don't know. I think we could consider it as an ambiguous cap. We can maybe guess it. There are some small macro channels and from LAD, but I don't know. There is some calcification, maybe, yes, but I think I can consider it as an ambiguous cap anyway. We have a nice collateral from diagonal to diagonal, actually.
Okay, so we've got an LAD CTO. We've got severe disease in the proximal LAD going into the diagonal, and it looks to be a blunt proximal cap. The distal landing zone looks to be at the bifurcation with the diagonal that actually collateralizes it. And there's a good distal vessel beyond there with quite a few septal branches. And there may be some very tortuous looking connections from the distal part of the circumflex that come into the distal LAD is the way I'm seeing that anatomy.
Yes, IVS puncture is okay, but if you can use a dual lumen microcatheter, it's a very good option also because you try to find a way for ways to puncture antegrade. You can put a wire in this dual lumen in the diagonal, and then you try to get a...
Yeah, it's a great suggestion, and they're not mutually exclusive. You can mark fluoroscopically where you think the cap is, and then you bring your dual lumen microcatheter down and use it as a platform to try and get in to the vessel. So, Ömer, we've suggested IVUS, possibly a dual lumen microcatheter. You're in the room. What's your view of the proximal cap and what's your approach?
So I fully agree with your thought and what you said. Yes, we have actually several options here. I think, as you said, first option could be a IOS guided puncture. We can do it, of course. If you like to do this case a little bit faster, I think, to me, in my routine, daily work, I like to go that retrograde collateral to see at least where is my wire, because yes, I can see hopefully with the IOS, but I agree with you.
I'm not sure I personally fully understand from the angiography where the interventional collateral is. Can you just clarify where you feel it is, and anyone in the room as well, if you can see something, point it out to me.
Okay, let's show you again then. All right. Yeah, okay. If you see diagonal at the distal, we have 2 branches. One is go up, one is go down. That one, and at end of the diagonal, I have a collateral. I think that collateral goes to diagonal. What do you think? Am I right? Or
what looks to be actually a very straight epicardial connection.
So what kind of wire do you have now?
No, this is a workhorse wire for me just to engage. I have here, I have a carawel. If I have short time, let me allow you to do this case retrogradely. Sion, please, Sion.
So this is
a side branch.
What is this wire?
This is Sion now for retrograde. I mean, I was in that collateral. I have to go again, and this time I have small curve, but it's okay. Yeah. Now you see, I am LAD now. That's what I'm thinking.
You've now got a really short occlusion with a completely ambiguous distal cap. You've now defined the proximal cap, and you're just going to do exactly what you would do with an antegrade wires case. So it's a really nice demonstration. You're going to start with a low tip load polymeric wire. If that doesn't run, you can escalate as you see fit. So I think it's operator's choice really. There's not certainly don't need to use anything particularly aggressive up front.
I still think there might be a microchannel, so taking low tip polymeric wire like Fielder XTA, XTR doesn't doesn't is quite good, reasonable choice, I think.
This is C on black now. I thought I have a
Obviously
channel and let's try if I cross it, but it seems that I have, let's see. And I also thought that we have some disease part. Hopefully I can cross with this without, let's see. Guy, a second please. No, I like to do ballooning from LAD to diagonal. Maybe it's better because we have a disease part here. Can I have 2.5 balloon please?
So you're always thinking 2 or 3 steps ahead. I'm going to try with a stiffer plaque wire. Okay, that's not gone. We're trying to go retrograde wiring into true lumen, into a disease segment. So Ömer wants to reduce the disease, so there's got a bigger target to wire into.
Exactly.
But then if the problem is penetration, then you can use a stiffer wire. And then finally, what's perfectly reasonable is we normally want to make connections if it's difficult in the CTO body. So you've now got a wire in position, you've got a perfect target, and now you can just bring forward an antegrade piece of equipment, microcatheter, and puncture antegradely towards that wire. So I think I would have a very low threshold for doing that fairly early on if we're starting to work retrogradely and things aren't working for us. Why? Because we want to come away with that diagonal branch. We don't want to compromise that.
Great.
Yeah, but we have some disease part here.
Yeah, we've still got to we've still got to make sure that we use our due diligence, that we make sure that we've not lost, you've not sort of crossed and re-entered or covered a flap across your diagonal.
Some antegrade.
Let's have a Sion now to go more safe. You see that when I up here, so I think I had better to use double lumen catheter to cross that LAD in that part. So let's do proper retrograde, ping pong technique here.
Okay, so then, finally you've got this sort of ping pong technique where you can bring in another guide, wire back into the other guide, have a traditional system, and then you've got all options available to you. Yeah. So the problem is that sometimes in CTO you've got an embarrassment of opportunities. You've got so many opportunities. You've got to choose which one feels most comfortable for you and get really good at doing it. As long as your focus is to make sure that you come away with both of those branches and that we don't lose control of the vessel along the way. But what we've seen here, we're going to move away from you, Ömer, now and let you carry on working. We'll come back and get the final result in the next session. But we've seen a really beautiful, simple epicardial crossing followed by retrograde wiring and now resolving the externalization and changing out to antegrade. And you've seen that all in about 10-15 minutes. So much kudos to you, Ömer, because it's not an angiographically straightforward case. Well done.
You know what I do when I use? We always do radial approach. 95% maybe, and we stir the sheath to do wrist because this sheath very slippery.
It comes back down to what we were discussing, you won't know with Argo today, is that even when I've got a beautiful ipsilateral collateral, I'll always have dual catheter access, dual vascular access, because sometimes you do want that second guide. You don't want to have overlapping equipment. You can do it, but you don't have to do it. Exactly. And if you've got more options available to you, then things can be generally safer. Yeah. So we're going to let you work, and we're going to go to... we've got we're well behind time. Should we close the session, go to the coffee?
Okay.
Yeah, so it's been a great session, everyone. We're going to kick back the lectures till later on in the afternoon, so you've got those to look forward to. One of them is mine. It's going to be fantastic. So please do come back, don't all leave. And great session, thanks a lot.
Thanks.